Good evening. Thank you all for who have come here to listen to our IC on retinal dystrophies. As we all know, retinal dystrophies, ERG, genetics, these are all areas which are often not given the due importance. But in the recent years, everywhere it's been happening, and we are trying to understand more about retinal dystrophies and and trying to do something, whatever little bit we can try to do for these unfortunate patients. So this is a humble attempt by a group of us who are trying to learn more on IRDs and improve our care for these patients. So I call upon Dr. Divya, Senior Vitreoretinal Surgeon at LF Hospital, Angamali. She'll be giving an overall idea about how to approach a patient with inherited retinal dystrophy.
So at the outset, I would like to thank Dr. Lekha and KSOS for having me here. So I'll just briefly give an outline and will not go to the specifics of it. That will be covered in the subsequent talks. So approach to inherited retinal dystrophies. So as we all know, when you think of inherited retinal degenerations or dystrophies, it is genetically and phenotypically, it is a heterogeneous group and that share a progressive, variable progressive loss of photoreceptor function and which eventually leads to vision loss. So even though it is inherited, we think in terms of like genetic, it may not be present right from birth, it can manifest later. And the other aspect of it is that need not everybody will be having a history, family history. Only 60% of them might be having a family history. So when you think in terms of IRDs, we think like in various disease classification, that is depending upon primarily which cell is affected. So it could be photoreceptor, it could be RPE, it could be a combination of this, it could be Muller cells, or eventually the choroid also might be affected. And you will get some clue depending from the history by the age of onset. When it is like too young, like infantile origin, then you think in terms of diseases like LCA, achromatopsia. Little later, it is like Stargardt's, or in adulthood, you can present like even adult onset retinitis pigmentosa, autosomal dominant retinitis pigmentosa, pattern dystrophy, etc. And by the clinical course, so some can be progressive, some may be stationary. So progressive like retinitis pigmentosa, again choroideremia, and the inheritance patterns although would be differ. Like the could be autosomal dominant, recessive, X-linked, mitochondrial, and some would be having syndromic association, and some would be purely ocular involvement. So main thing is that you have to identify that it is an IRD. Second is like when you identify, you need to think that whether it is purely ocular or whether there is any systemic association, that is syndromic. And second thing is that whether this could be a progressive one or whether it is non-progressive. So two important things you have to keep in mind. And many of times when you have these syndromic associations, so of late they can be, it was attributed to ciliopathies. That means like these cilias are cells which is present in almost every human cell. So many of this systemic, why these various organs are affected, so they looked into this. So there's a various syndromes where dystrophies are associated with other systemic manifestations like auditory, renal systems, cardiac involvement, cerebral and neurological involvement, skeletal anomalies. So there is a huge list of it. And so how do we approach these cases? So first we have to get an idea whether it is inherited. So from the history and the systemic, if you're thinking in terms of a syndromic, elicit from the history if there is any systemic involvement. And always ask about the family history. And then do you have to do a comprehensive ophthalmologic and systemic evaluation. So from the clinical history, when you ask the symptom profile, whether the patient has difficulty in night vision or a day vision problem, whether the peripheral field loss is there, color vision is affected, and what is the refractive status of the patient, whether the child had nystagmus or has nystagmus, and how much is his functional disability the child or the patient has. And when you think in terms of systemic, because you need to rule out whether it is a syndromic. So ask about the systemic history, like renal involvement, whether examine the general physique of the patient. So you pick up many of the anomalies. So don't get into the habit of looking directly into the retina or the eye. Just see how the patient walks into your OPD, what is the physique, whether the patient is obese. Then look at the fingers, toes, whether there is a polydactyly. Look for any neurological signs, any skeletal anomalies, and again try to screen the family members also, and take a proper birth history and a developmental history. So age of onset, and the rate of progression from the history actually helps to gives you some clue regarding the IRD what you are dealing with. And now coming to the clinical examination, so first thing is that the visual acuity the child or patient has, then you see whether the patient has got any other of ocular involvement like cataract, any keratoconus, or any anterior segment anomalies. Then look at the fundus. So when the vision is poor or low, you have to explain why the vision is low from the anterior segment. Look at the fundus, whether any disc anomalies, whether macula is affected. If the field, look at the periphery, how the vessels are. So all these findings you should explain what the vision loss has caused. Then coming to investigation. So after your systemic examination, the ophthalmic examination, now you move on to the investigations to differentiate these entities. So always take a picture fundus photograph to document at least the progression and look the changes. And then look autofluorescence. It is a very good tool actually to pick up any progression, because that gives a broader view than an OCT which looks at specific areas. But the OCT will help to differentiate many entities, like whether the macula is involved, macula is spared, or any other abnormalities at the macula. Then visual fields, and then ERG is another test. So the details of it will be covered in the subsequent talks. Then another test is microperimeter, especially in the era where we think of genetic therapies and all. So ERG, especially in cases of like RP or chondrodystrophy, many of them it would be extinguished. So you think in terms of other investigations like microperimeter, full stimulus threshold, where the ERG is absent, still if some residual cells are functioning, it will be able to pick up. So these tests actually help to know whether the patient is eligible for gene therapy or what is the response to this therapy. So genetics, actually you will know what is the inheritance pattern, and if it is a carrier, then you will be able to pick it up. And in some diseases you want to know the prenatal screening also. So as I mentioned, it helps in diagnosis. The details will be covered in subsequent. Again, the talk is there. So to know again helps to know whether the systemic involvement is there, and we need to send the patient for any systemic evaluation. And also again prognosis, the rate of progression, and then the feasibility for gene therapy and prenatal screening. So when do you do ask for a prenatal screening? When there is a strong familial history of a very severe retinal dystrophy, or the dystrophy is severe and early onset, in cases of syndromic. And systemic investigation, as I already mentioned, when there is a syndromic association, you need to look for accordingly whether the audiogram has to be done, or an ultrasound abdomen, and then endocrinal profile, then metabolic abnormalities, the biochemical test related to that, cardiac evaluations, all these things depending upon the systemic involvement that you anticipate from these cases. And you have to monitor some, once you have diagnosed what is the rate of progression. So the tools like autofluorescence, then OCT, visual field, and the full stimulus threshold test, all these helps to detect you if there is any progression. So autofluorescence is a very useful tool actually to pick up in one glance whether there is a progression or not. And what you can do for these patients, because now the gene therapy is coming more, but it is not widely available, or it is evolving only. So what are the other options? Like lifestyle modification and counseling is very important, like the protective glasses. Then don't give vitamin A supplements for all these patients, because unless you have a genetic diagnosis, sometimes it may do more harm than good. And one very important thing, the importance of genetic, especially when you pick up these and identify these cases, diagnose early enough, because many a times you come across these patients who has diagnosed with IRDs later and have taken up some profession which, like, after they have took the course, they realize that it is not suitable for them. So that actually helps them to pick up a course and study accordingly to their diagnosis. And don't forget that it is not IRDs, but there can be association with other ocular diseases like cataract. So sometimes, especially in RP patients where in the autosomal dominant, the vision might be less. You get an OCT done, see if the fovea is spared, and if you see a posterior subcapsular cataract, then operate the patient. That will be useful for them. Then they can have choroidal neovascular membranes, cystoid macular edema, which usually in those cases we treat it with acetazolamide inhibit drugs like that. And then they can have even retinal detachment. So don't forget to miss those findings if they come with a sudden decrease in vision and macular hole. So this is one of the case with the IRDs with the CNVM. So you treat them with anti-VEGF injection. This is a case of macular hole. So you can take the patient for a macular hole surgery. So to conclude, first you confirm the diagnosis, baseline imaging has to be done, genetic counseling, then whatever you can done for vision preservation, the treatment options available, low vision, and the psychosocial support and follow-up monitoring. So this should be the outline. Thank you.
Thank you, Dr. Divya. That was a quick overview of how we have to approach a patient with IRD. I'm sure there will be doubts, but then as we go about more about it, we'll understand it in more detail. So now I call upon Dr. Neena, who is the head pediatric ophthalmology and neuro-ophthalmology at Giridhara Institute. She'll be making electrophysiology a little more simpler for us, and she will continue with few of our cases where it has helped in the diagnosis and management.
Thank you, Dr. Lekha and KSOS for this opportunity. So at the outset itself, I'd like to give a disclaimer that I'm not a retina specialist. I'm a pediatric ophthalmologist who started doing electrophysiology out of my interest. And I try to do justice to the topic by making it simple and understanding for you. So that when you talk about visual electrophysiology, the three tests which come to our mind are ERG, EOG, and VEP. So this picture in a nutshell tells you from where the potentials are recorded, and I will tell you what is ERG. So you can see here that it is nothing but a corneal measure of the electrical potential generated by the retina in responses to changes in illumination. And so how is it done? You can see in the picture, after pupillary dilatation, the patient is subjected to 25 minutes of dark adaptation, and electrodes are applied, and the dark adapted responses are recorded. Then a 10 minutes of light adaptation is performed, and the light adapted responses are recorded. So basically, when we talk about DRG, we are talking about flash ERG or full field ERG. Then there is a pattern ERG, there is a multifocal or focal ERGs. So I'll explain each one by one. So this is how the printout of a full field electroretinogram would come. You have basically the dark adapted responses on the left till here, and then the two light adapted responses. So standard ERG would consist of a dark adapted 0.01 response, where you have a small A wave and a prominent B wave, and then you have the maximum rod cone response, which comes in the form of dark adapted 3 ERG, and then there's a dark adapted 10.0 ERG, and then the scotopic oscillatory potential. So these are all dark adapted responses. And then you have the light adapted 3 ERG and the 30 hertz flicker, which is the response from the cones. So how do we interpret this? As I already mentioned, there is an A wave, then there is a B wave, and on the rising arm of the B wave, you have the oscillatory potentials. So we have to look at the latency of each wave, the implicit time, and the amplitudes. So how do we interpret? So, you have to look at which part of the ERG is grossly affected. Is it the rods which are affected? Is it the cones which are affected, by looking at whether the light responses are affected maximally or the dark responses are affected maximally, and whether both are affected. And remember that if you look at the maximum rod cone response, that is a dark adapted 3.0 ERG, you get most of the information from that. 70% of the information is got from that response itself. So when do you order electroretinogram? That's the doubt which is there in everybody's minds. So as already explained by Divya, when you have a suspected photoreceptor dysfunction with normal fundus, please do order ERG to confirm your diagnosis. Or if you have a confirmed photoreceptor dysfunction, then also please order it so as to further confirm it and to assess the residual retinal function. In all inherited retinal dystrophies, please do ERG, because it may not be what you think. You may think it is RP, but it may not turn out to be RP when you do the ERG. Autoimmune retinopathies, it's mandatory. Suspected drug toxicities, vascular occlusions, you can do to assess the prognosis. Intraocular foreign bodies, you can prognosticate the visual recovery before you do the surgery. And any patient with vision loss of unknown cause, please do resort to electrophysiology, especially if both ERG and VP can be combined. So this is how you interpret it. You look at the latency and amplitude of each wave, and also confirm the patient's details. So you can see on the left hand side, I've given the normal waves, and on the right hand side you can see this is a response from a patient with retinitis pigmentosa. You can see the rod responses are grossly diminished, whereas the light adapted responses are okay. In case of road dystrophy or cone dystrophy, the rod responses may be fine, but the cone responses may be grossly diminished. So I will be touching only the basics because so that just an overview of this thing. But please remember that ERG does not have a great localizing value because the flash ERG is affected only if the retinal dysfunction is widespread. For example, you may have a patient with very poor vision, as in Stargardt's with macular atrophy, but ERG may be normal. Okay, so you have to do a multifocal ERG in that patient to assess the depth of the damage. So it does not correlate with visual acuity, and it also does not reflect ganglion cell function. So a lot of other things can play havoc with your ERG measurements. So this is something that you have to keep in mind. Next, moving on to pattern ERG. This is not very commonly utilized, but it's a wonderful tool if you have a patient with vision loss of unknown cause, because it can differentiate optic nerve pathology from macular function. So you can look at this wave. What does it do? It's an electrical response to a pattern stimulus, just like you have a pattern VP. You're recording the ERG to a pattern stimulus. So you have the N35, the P50, and N95 waves. And it is said that the P50 is basically from the macular photoreceptors, and N95 is from the ganglion cells. So you see which wave is more affected. If the P50 is more affected, it's more likely to be a macular pathology than an optic nerve function problem. And if it's N95, it's more likely to be a optic neuropathy. Coming to multifocal ERG, it is a local ERG response recorded simultaneously from a focal area. Mostly it's done for the macular area. You have the central 25-degree recorded in this array fashion, and it is plotted like this. So what is its use? For example, you have a patient with HCQ toxicity, you want to do some screening, or you want to see if it's affected the macula. You can look at the foveal peak. You can see the normal foveal peak is here, and you can see that the foveal peak is depressed. So this may happen very late in the disease. All HCQ toxicities, it's not very common, and HCQ is very safe drug to give. So please don't jump into a small change and diagnose as HCQ toxicity. You have to document it serially and be sure about it. Moving on to electrooculogram, it is nothing but the standing potential of the eye, which is measured. There are two components. There is a positive anterior aspect of the cornea, which is the changes from the anterior positive aspect of the cornea is measured in relation to the negative posterior aspect of the retina. So there is a light sensitive light peak by the rods and cones and a dark trough generated from the RP. So we are basically interested in this, this is how it is done. And we are interested in the Arden ratio, or the ratio between the light peak and the dark trough. So generally it's thought that anything which is less than 1.65 is abnormal, and sometimes you have subnormal values. You need to look at the graphs very carefully. So this is the typical where you do best disease, because you will find that the OG will be abnormal in this condition. Moving on to a bit about VEPs, because it's not complete if I don't talk about visually evoked potential. What does it do? It just tests the integrity and the function of the anterior visual pathway from the retina to the occipital cortex. And it's nothing, you can think of it like an EEG from the occipital cortex. So when the light is shown into the eye, it measures the electrical signal generated in the visual cortex. That's what you're measuring. And this is how the patient is seated, and this is how it is performed. You have the various electrodes. You have two basic types of VEP, the flash VEP and the pattern VEP, and you need to wear the correct refractive correction for pattern VEP. And when do you do what? So when you have a flash VP, it's a diffuse flash stimulus, but when you have a pattern VP, it could be either a pattern reversal stimulus or a pattern onset offset, which can be done. So a brief word about how you look at the parameters of flash VP. You have negative waves and positive waves. You look at the second positive deflection, which is the P2. You look at the latency of the P2. The normal should come within 125 milliseconds. Anything more than 125 is considered to be abnormal. And the P2 amplitude is usually more than 10 microvolts. So if it's less, then it could be reduced. This is again a normal flash VP, which is recorded. So you can see here in pattern VP is more specific, because it has a role in demyelinating optic neuritis and many other conditions, and it can also measure the visual potential in infants also. So here you are looking at the positive deflection in and around 100 milliseconds. That is the P100 that you're interested in. You're interested in the latency of the P100 and the amplitude. Normally it should come within 110 plus minus 10 milliseconds, and the latency is usually more than 5 microvolts. So you can see here this is a normal pattern VP, but the main indication for a pattern VP would be a demyelinating optic neuritis, and you have to also for malingerers you can try pattern VP. Flash VP, it is usually done and there's a poor visual acuity, poor fixation, dense media opacity, and infants to assess the visual potential, and also to monitor visual recovery in CVI patients. Remember that you can get, yeah, an intelligent malingerer can make your VP abnormal, so always do a flash VP for such patients. So this is the last slide I'd like to end. A pattern ERG is what Holder et al. Recommends. So if you do a pattern ERG and it is normal, follow it up with a pattern VP. If it's normal, it's non-organic. But if it's pattern ERG is normal and you do a pattern VP and it is abnormal, then you know it's an optic nerve dysfunction. You do a pattern ERG, it is abnormal. It is the N95 which is abnormal. So pattern VP is followed up. It's again abnormal. You know it's optic nerve dysfunction. Pattern P50 is abnormal. You know it's a macular problem. Do an ERG. If ERG is full field is normal, do a multifocal ERG. You will pick up the maculopathy. And if P50 is abnormal, ERG is abnormal, then it's a generalized retinal dysfunction. So that's what it says. It has a role in children also in vision loss of unknown cause. So thank you. Should I continue the next class? The next PPT. Yeah, so I'd like to share my experience, how and when electrophysiology and genetic tests has made the difference in my practice. And so the relevance is when you have an unsolved case, you use these tools of electrophysiology and then genetic tests, and please take help of your colleagues also, because more than one brain does help you here. So this was a 7-year-old otherwise healthy boy. He was referred to me as amblyopic. His best corrected visual acuity was 612 N6 in the right eye and 618 N6. No consanguinity, no family history, poor color vision. This is his optos picture. So maybe some temporal pallor. But when I took the history, there was definite history of stumbling of objects at night. So maybe he's having some night vision problem. I did the ERG. What does the ERG show? You can see here that both the scotopic and the photopic responses are reduced, but scotopic is more reduced, isn't it? The dark adapted responses are more reduced. And look at the maximum ROTCON response. You should get a nice B wave here, but where is the B wave going here? It is going below baseline. This is a negative B wave. So I'm thinking, is it congenital stationary night blindness? And that's when I sent him for a genetic analysis. They came out positive for TRPM1 mutation, though it came out as VUS or variant of uncertain significance in the relevant clinical picture. I think this is pathogenic. So all this is Greek and Latin to you, I guess, but even to me it was Greek and Latin till I read about it, because this transient receptor potential gene provides instructions to make proteins, which is necessary for night vision, especially for the on bipolar cells. So if there is a mutation in the TRPM1 gene, this does not function and results in complete CSNB. And that's when I understood, yes, so there is a problem here, and he does have a problem. So second patient was a 7-year-old boy with symptomatic seizures. He was definitely tripping and falling over objects. The pediatrician wanted to rule out an ocular pathology. This is the fundus. It does look like a retinal dystrophy, right? Like looks like retinitis pigmentosa, waxy pallor. You can see some mottling. That's what I also thought. Yes, his ERG was flat. There was no waves. So what are we dealing here? I told the pediatrician he does have a retinal dystrophy, and we decided to do an MRI. And MRI showed something very interesting, eye of the tiger appearance. So that's because of the accumulation of iron in the basal ganglia. And this, the pediatrician immediately recognized as a case of PANK2 mutation, an error in pantothenate metabolism producing this condition, previously known as Hallerden-Spatz syndrome or a pantothenate kinase deficiency. It was confirmed with the genetic test because of the accumulation of harmful metabolites in the brain and the retina. He was having problems of seizures and night vision. So this could be explained when we did the genetic testing and electrophysiology. The third patient was referred as degenerative myopia with bilateral pale disc. 13-year-old boy has developmental disability, high myopia, vision not improving beyond 6/60, poor color vision, but no manifest squint, pale disc, defective vision in both light and in dim light and dark. He had problems. This is his ERG. What do you see? You can see again the rod responses are reduced, but what is most striking is that There is non-recordable light adapted responses. Photopic responses are flat. So what is he having? So that's when I saw him. He was having polydactyly. So I was thinking, is this kind of syndromic retinal dystrophy? I was thinking that in mind, and I ordered this test, and he came out positive for MKKS gene, something which is similar to Bardet-Biedl, but without truncal obesity, without gonadal or renal agenesis, without congenital heart disease. It only has the retinal manifestations and polydactyly. So how does it help you? So this is again, as Divya mentioned, it's a ciliopathy. It affects the intracellular traffic and cilia function, and that's where the mutation is there, and that's when you get a retinal dystrophy, something like Bardet-Biedl. This patient, you can see the video, squeezes in daylight. He has poor vision, he has hemerotopia or day vision difficulty, nystagmus, and poor vision. Fundus looks almost normal except for some suspicious mottling. What is he having? Poor color vision. So basic problem is something to do with fine vision, which is moderated by cones. And that's when we did the ERG, and you can see that the light adapted responses are flat, isn't it? But the dark adapted responses are pretty good. So is this a problem of cone dysfunction? That's when we did the genetic testing and came out strongly positive for homozygous achromatopsia, CNG A3 gene positive. So you'll be wondering, how is the CNG? You've heard about the CNG gene, which is important in phototransduction, isn't it? So when you have the CNG channels open up both in rods and cones, they're very important in phototransduction. So if you have the cone CNG channels which are involved, you get achromatopsia, that is total cone dysfunction. Okay, and when you have the road channels affected, you get retinitis pigmentosa. So this here, it was in the cones, and that explained the condition. So my last case is this, a very interesting case, a 13-year-old boy who came to us for a second opinion for subnormal vision. He was wearing glasses for the last 9 years, otherwise healthy, but there was second degree parental consanguinity. So this is how his anterior segment of both eyes were. When I saw him a few years back, he had shallow ACs and some peripheral anterior synecdoche with iris atrophy. When we dilated, I was in for a surprise. He was microspherophakia. So, and this were pale, looked like glaucomatous cupping to us. So axial length was evaluated normal. So this was lenticular myopia due to the globular lens. So this here was our patient, high myopia, microspherophakia, shallow AC, iris atrophy, high IOPs were also on the higher side, glaucomatous cupping. What are we dealing with? It's a syndromic, definitely a syndromic case because parental consanguinity is there. So we advised genetic testing, but however, they did not do that. They came back to us and we started him on AGM, and YAC-PA was done in both eyes. IOP was kept on normal with follow-up and AGM, and he was on regular follow-up till he came back to us in July 2025 with sudden drop of vision in the left eye and pain. No history of trauma, 6.6 in the right eye, but CF 3 meters in the left eye. IOP recorded by optometrist was normal. This is anterior segment. You can see apart. There was no corneal clouding, but AC was very shallow in the left eye. You can see the slit section. The cornea was it was touching the cornea. Post dilatation, the same findings, microspherophakia. So what's the cause of the defective vision? That's when we saw the fundus. If you can notice, there are fine ILM folds in the macula in the left eye, suggestive of a maculopathy. That's when I thought, is he having maculopathy? I first thought it was due to inflammation, and rechecked the IOP, came out as it was 3.2. So it was hypotonic maculopathy, and was it RD, CD? All these things we ruled out with B scan, no RD, no CD. And AGM was stopped. He was put on a bandage contact lens, and he was sent to my colleague Dr. Lekha for a second opinion because I thought it must have been an inflammatory shutdown, ciliary body shutdown. That's when she picked up these patches of scleral thinning at the limbus, which is suggestive of a spontaneous scleral filtering bleb. So this is a very rare condition. She had seen a similar case earlier, and so she was able to identify this. The younger brother also has the same condition. Maternal aunt also has the same thing. He has a particular facies, malar hypoplasia, beak nose, retrognathia. So she thought about this condition called Shava-Trabulsi syndrome. And that's when we sent him for further systemic evaluation. He had cardiac parameters positive, diaphragmatic hernia, and he came out positive for ASPH gene, which is coding for Trabolsi syndrome, mutation in the ASP gene. So it's a very rare syndrome, but remember that all subluxated microspherophakic high myopes are not Marfan's. They could be having this phenotype. So that was just a big eye opener. Thank you very much. So
Thank you, Nina, for that wonderful collection of cases. And it is some of those are like we do see and we miss those cases actually. So I think the genetics and those investigations help us to pick up those cases. Now I welcome Dr. Lekha, senior consultant at Giridhar Eye Hospital, for her next talk on genotype phenotype correlation in macular dystrophies.
So, thank you. And I thank KSOS for accepting this IC, and I hope slowly we will sensitize more people to take interest on this topic. So, the previous two speakers have given a good introduction. So, my aim is to give a little more clarity on the macular dystrophies, which are those subset of IRDs where predominantly you find macular abnormality, usually bilateral and symmetrical. And obviously, they will cause a problem in the central visual function. A systematic approach is important for diagnosis. Most of the time, we may not have a definite treatment now, but that does not mean that nothing can be done for these patients. And the understanding in genetics have told us that most of them are monogenic or linked to one gene or few specific mutations. So they are actually potential candidates for gene therapy. And these are the three most common macular dystrophies which I am going to cover in this topic. Just to touch upon the genetics, we all know that we have genetic material in the form of DNA in the nucleus of the cell. And these genes contain instructions for making the proteins, which in turn determines our cellular function. So when you have a normal gene, you have a normal protein and a normal function. But when you have a mutated gene, you either have an altered protein or no protein at all. And obviously the function is going to be different. And that is what which is reflected in the phenotype that we are seeing. So this is a 12-year-old girl with defective vision since 1 year, mainly the central vision. You can see the color vision is normal, and the fundus view as well as autofluorescence shows us the typical flags of Stargardt's disease, and OCT showed foveal atrophy. Field showed a central scotoma, and full field ERG comparing to the normal, we can see all the waveforms were normal. Genetic testing confirmed a pathogenic variant in ABCA4, confirming the diagnosis of Stargardt's disease. All straightforward here. So this is a second case. He is a 45-year-old male, defective vision since 30 years, again started by the second decade. He also had defective color vision and side vision. Family history was also positive, and we can see that his both vision and color vision are markedly reduced. Much more extensive fundus changes compared to the previous patient, and again on the autofluorescence, we can see extensive hypoautofluorescent lesions, extensive EZ loss on OCT, and significant field effect. And in the ERG, we can see that the rod response is reduced, but it's the cone response, it is reduced more than the rod response. And genetic testing again showed a pathogenic variant in ABCA4, but due to cone rod dystrophy. Third case is an 18-year-old male with defective vision since 1 year. He had, apart from central vision problem, night vision, color vision, side vision, everything was affected. Fundus picture almost looked like an RP with changes extending to the mid periphery, extensive EZ loss on OCT, advanced field effect, and reduced waveforms, both cone as well as rods affected. And here also it was ABCA4 with retinitis pigmentosa as the diagnosis. So I showed you three different phenotypes. All had problem in the ABCA4. So this ABCA4 retinopathy is actually a broad umbrella term and involves heterogeneous group of conditions. So let us try to understand little more about ABCA4. ABCA4 stands for ATP binding cassette, subfamily A, member 4 gene, and it encodes a very retina-specific transmembrane protein, which has an important role in the retinoid cycle. So retinoid cycle is what happens when the light falls into a photoreceptors. The rhodopsin is converted into all transretinal, and a series of changes happen, leading to the formation of certain byproducts. And it is this ABCA4 which translocates these products from the inside of the outer segment disc to the cytoplasm. And when you have a dysfunction of the ABCA4, there will be buildup of these visual cycle byproducts, which then integrates with the lipofuscin in the RPE, leading to dysfunction of the RPE and subsequent degradation degradation of the photoreceptors. That is how a problem with the ABCA4 leads on to the changes in RPE and photoreceptors. So with this understanding, let us try to see this. So when you have a normal ABCA4, the rods and cones are intact, waveforms are normal, and fundus is normal. When there is a partial dysfunction of ABCA4, there, there may not be much of visible injury to the rods and cones, so the waveforms may be normal, but you see the changes of Stargardt's disease. But when there is more severe dysfunction of ABCA4, there is definitely more damage to the photoreceptors, especially the cones. We can see there is some thinning of the RPE and more accumulation of these toxic products, the bisretinoids, which is also reflected as decrease in the waveforms on ERG, and this is what you get in cone rod dystrophy. And if the ABCA4 is totally absent, there is extensive apoptosis of both the rods and the cones, significant thinning of RPE, absent waveforms, and you get the picture of retinitis pigmentosa. So ultimately, it depends on the severity of the genotype, the sensitivity of the foveal cones to the genotype, and the sensitivity of the RPE to the genotype. So what can we do to these patients? We have heard it before, gene therapy or stem cell is still in the research level, but we can try to do something which is called as a pharmacotherapy by utilizing agents for their anti-inflammatory or antioxidant or neuroprotective effects, which can try to reduce the accumulation of these byproducts, and various agents are being investigated, of which one such agent is metformin. Because of its safety profile, affordability, we are also undertaking a trial on the role of metformin in Stargardt's patients. Supportive measures are extremely important. It has already been touched upon by Dr. Divya. And again, I would highlight that avoid any kind of supplements, especially the antioxidants, because it might do more harm than good. And this is a practice which is still continuing in many places. Just because we don't have anything to do, that does not mean that we have to give antioxidants. This is a 55-year-old lady. She said she has been having subnormal vision in one eye earlier, but little worsening last 1 year. Vision was reasonably okay. Color vision was normal. We could see yellowish deposits in the foveal area in both eyes with hyperautofluorescence on FAF and hyperreflective subretinal material on OCT. Field showed few central defects. Full field ERG was normal, but EOG showed a reduced Ardens ratio suggestive of the variant of Best dystrophy, which is the adult onset fovea vitelliform dystrophy. So if you see the phenotype of Best disease, the very first stage is actually a preclinical stage where you need imaging to diagnose it. But the classical lesion is a typical ear-gluque vitelliform lesion, which can progress to pseudohypopion, vitelliruptive, or even atrophic lesions. And the causative gene is the BEST1 gene, which is located in chromosome 13. It encodes bestrophin, which is located exclusively in the RPE, and its main function is a channel protein. This regulates the flow of chloride ions in the basolateral membrane of the RPE. So chloride is important for fluid balance and generating electric signals. So basically, it has a lot to do with the RPE pump function. So when there is a mutation in the BEST gene, there will be loss of this pump function. So RPE becomes swollen and unable to process the debris. So all the debris will build up, and that causes a physical barrier. And the deposition of lipofuscin causes more damage to the RPE and photoreceptors. And eventually, with the breakdown of blood-brain barrier, abnormal vessels can also grow, leading to the formation of CNV. And this is one indication for intervention in BEST disease. Now, this is a 7-year-old boy with defective vision detected at school. Family history was positive, but note that it is the brother and the uncles who are affected, and both parents were born of consanguineous marriage. Vision was 624, color vision also mildly affected. A careful examination, which can see could some skytic changes, but it's not so clear in this photograph. But it is very well seen on OCT, especially the wide field OCT, which showed that these changes extend much beyond than what could be seen clinically. And ERG showed the characteristic electronegative B wave, which is suggestive of juvenile X-linked retinoschisis. This is due to a defect in the RS1 gene located in the X chromosome. It is inherited in an X-linked manner. And this encodes for the protein retinoschisin present in the bipolar and photoreceptor cells. It has an important role in cell-to-cell adhesion. It is also important in signal transduction. So this explains the phenotype now. It also regulates the fluid balance and tissue osmolarity. So because it disrupts the adhesion, you get the skytic changes, the emergence of fluid-filled cyst, and the signal transduction is affected, so you get the electronegative ERG. So that's how you correlate the genotype with the phenotype. So they present with central vision loss, and by second decade, foveal schisis is seen in 100%. Rarely they can have complications like retinal detachment, vitreous hemorrhage, etc. So dorzolamide has been tried, and if they develop complications, surgery is required. There is no role for any laser, and they should be advised to avoid contact sports. So to conclude, our understanding of macular dystrophies have greatly improved. Multimodal imaging and electrophysiological test has helped us to characterize these lesions better. Genetic testing have helped us to understand the molecular basis, and because it is now more accessible and affordable, we should have a tendency to investigate them on the genetic side also. So future direction would be therapeutic strategies which can halt or slow the visual loss or even restore visual function one day later. This involves a team approach involving retina and pediatric ophthalmology specialists, because most of them will be coming to the pediatric ophthalmologist, geneticist, and a genetic counselor. Thank you.
Thank you, Dr. Lekha. Dr. Rajiv Sukumaran wants to make an announcement. Yeah, we will continue Dr. Bhattu's talk after the announcement.
Good evening, everybody. I'm calling the general body to order. This is just a formal announcement so that I can adjourn it for half an hour for want of quorum. So I'm adjourning it and we'll gather after half an hour. This is for official record.
Okay, thanks. Yeah. So now I call my dear friend Dr. Rajni Bhattu. She has come all the way from Bangalore to join in this IC, and it is an honor for us to have her here. She is the Chief Medical Officer of iSTEM Research and a Senior Consultant at Aster CMI Bangalore. After her MS from St. John's, Bangalore, she had her FRCS from Edinburgh, training in Vitreoretina from Shankar Netralaya, ICO fellowship from Moorfields, and a PhD in inherited retinal disorders from Maastricht University, Netherlands. So she is going to share her experience with us. Over to you, Rajni. Welcome you for this
Thank you.
IC.
Thank you so much, Lekha, and KSOS for this. When I hear this, it looks like I've only been studying and doing nothing else. So, my previous speakers have done this, my job, really simple. All of them have really touched upon why we need to do genetic evaluation, but I'm just sort of going to organize this a little more. So, we've heard all of this. So you can have mutations either in the RPE, in the outer segment of the rods and cones, or in the inner segments, and in any of these, biochemicals of the visual cycle. Now, I'm not going to touch upon this. We've heard enough of all of this. Now, why do we need to do a genetic testing? Of course, for a precise diagnosis, because it's like someone having fever for a few years and we don't know why it is so. So having a precise diagnosis helps in prognosticating. It's easier to tell a patient, how long they're going to be able to see. Because I think one of the biggest questions, major questions that patients have is, even if we're not able to treat them, the question that haunts them is, am I going to go blind? If so, when am I going to go blind? How many years do I have? So, to a large extent, doing a genetic testing does help in prognostication, and definitely to look for possible therapies. I think because this field of genes, and genetic therapy has exploded in the last, decade or so. So, I do think there's a lot on the anvil. And most importantly, I think Dr. Divya mentioned family counseling or prenatal diagnosis. I'll just touch upon a few cases just to explain each of this. So this is, two sisters, non-consanguineous, parents, lawyer, parents, and the older one was a very shy 8-year-old girl, had a fever for about a week, following which she said she wasn't going to go to school. So two examinations done. Incidentally, this child is from the US. Two examinations done in the US, both showed that the vision was about 618. Seen by I think general ophthalmologist, and felt that there was nothing wrong, and the fundus report normal. The child was actually referred to a child psychiatrist. So on examination, her vision was about 624 each eye, not improving. Anti-segment was normal. This was a fundus. While on first look, it does look completely normal. There is a bit of a sheen at the macula that you can make out. Maybe it's also because we see a lot of these children. So when you do the autofluorescence, look at how enlarged the area of hypoautofluorescence is. So this is why I think my previous speakers were also telling us how important autofluorescence is in examination of children or adults with unexplained vision loss. So when you do the OCT, you see this significant loss of photoreceptor layer all throughout. And remember, it's only an 8-year-old child, and her full field ERG was difficult, but they found it was normal. So the diagnosis was varied. A diagnosis of autoimmune retinopathy was made, whether it was retinal dystrophy, whether the child was malingering. In fact, this child was told she has autoimmune retinopathy and advised a whole body, a PET CT to pick up any malignancy. So when I saw this child, to me, this was a retinal dystrophy. And eventually what we found was that this child did have, two mutations in the ABCA4 gene. So this is an early onset Stargardt disease. And I insisted that I examine the 5-year-old sister. The parents were hesitant, saying she's completely okay and there was no need. But the child had no complaints, cheerful. Vision actually improved to 6.6, when we treated her for her amblyopia. And this was her fundus, antisegment normal. This was a fundus, a normal looking fundus. Now, when you do the autofluorescence, there is a mild enlargement, but I wouldn't really give it too much importance. But here's what the OCT showed. So do you see this thickening of the ELM? So this is very characteristic of a subclinical stage of early onset Stargardt disease. Now, again, unfortunately for the parents, this child also had 2 mutations in the ABCA4, and this is a very distinct entity. Early onset Stargardt disease, I probably in the last 15, 18 years have seen at least about 6 children with early onset Stargardt who don't get diagnosed in time because the only a symptom they come up with is blurred vision. And unless you investigate, you can't make out that there is something wrong at the macula. So they're typically present between the age of 7 and 9, and abnormal autofluorescence and OCT. And unfortunately, they have quite a bad prognosis. So the ELM is, one of the hallmarks in early onset, Stargardt disease. So these children tend to drop very rapidly to about 660 by the age of, 12 or 13, which is not the usual case with, the routine Stargardts that we see. So we've heard enough. This is how we, see a typical retinitis pigmentosa. Now, what happens if it is not, what we see as a typical, the bony spicules, the arterial attenuation, waxy pallor. Now, this was a builder's son, a 25-year-old, a builder's son from Bangalore. He had actually undergone LASIK because his vision was poor. They had some, refractive error, had undergone LASIK. He basically came with difficulty, headaches and difficulty in vision, and consanguineous parents and only son. And vision was about 660, not improving, and really vague, refractive errors following the LASIK, unfortunately. This was his fundus. You don't see anything typical. In fact, what you will see is probably what looks like, a coat-like appearance there. That's in both the eyes. And even the autofluorescence is not a very classic, retinitis pigmentosa. And again, on the OCT, if it's a typical retinitis pigmentosa, you would sort of see the central preservation of the, outer segments. Here, there's a diffuse loss. So ERG did show a significant, rod dysfunction. And so this patient had what is called a CRB1 mutation or a Crumb's homolog. It's important because these patients, again, unfortunately, lose vision quite rapidly. And one of the hallmarks of them in the OCT is a very thick OCT that you saw. If I go back to the OCT, look at how thick the OCT is with sort of very diffuse lamination compared to a normal OCT. So this is very characteristic of a CRB1 mutation. CRB1 can also cause a form of LCA, but this gentleman had retinitis pigmentosa. So this is, this case is a diagnostic dilemma that I think a lot of people have heard from my, enough number of times, because I still want to talk about it just so that we don't miss these, patients. This was one of the first patients that I saw, a 20-year-old who, was being treated for bilateral panuveitis and angle closure glaucoma, had been on steroids and azathioprine for a few years, and on maximum medical therapy, significant visual loss, unfortunately. As you see, a very, very shallow AC, in spite of it, there is a YAG iridotomy that you see there, and that's the typical fundus. I'm going to do a close-up. So you see these changes at the macula, which is sort of vitelliform deposit, and the significant, disc cupping, of course. And when you do an autofluorescence in these patients, you see this significantly lit up macula. And the OCT will, of course, the angiogram was not, anything significant. When you do an OCT, you see these not only intraretinal fluid, you'll also see the subretinal fluid, and these sort of typical hanging, outer segments that you see. This is very characteristic of the recessive BEST that I think Dr. Lekha had alluded in another talk. So, of course, this patient had, while there was a rod cone dysfunction, the patient also had an abnormal EOG. These patients are very typically, they present to either the uveitis specialist or the glaucoma specialist. So they do not present to the a retina specialist. They carry a recessive West gene, unlike Dr. Lekha showing you the dominant vitelliform, the yellow lesion that you see at the macula. These patients typically present to the uveitis department. And I remember when I started looking at these, a series of patients. I picked at about 12 patients in a matter of a year, all of whom were being treated for glaucoma or uveitis. And so it's important that these patients are diagnosed correctly. Of course, we did a genetic testing and we did find that this patient had 2 copies of the BEST1 gene. One of the important, sorry, let me. One of the important aspects of this disease is that 50% of patients have only angle closure glaucoma in the absence of a retinal finding. So it's very important to really look at the extended families in these patients. So at least you treat the glaucoma, and even if they don't have a retinal finding. The second important aspect of this is these patients typically don't do very well either with the trabeculectomy. Most of them will require an anterior hyaloidotomy, which is when both the AC settles and also the retina. So that's another important bit of ARB. Another 2 sisters. This is the older one was, I think they're now 17 and 13, consanguineous marriage. How do we look at therapy? We looked at diagnostic dilemmas. What happens as we go ahead looking for therapies? These are 2 children who present typically with what looks like LCA. The fundus is more or less normal. So this is very characteristic of the RP65 gene that we all talk about, Luxturna and gene therapy. So this is how these children present. So this is the older sister, and what is also important is how well the retinal architecture is maintained, unlike other LCAs that you see where there's significant loss of rods and cones. This is in fact one of the reasons why RP65 was picked up for the early gene therapy that we are aware of. So significant field loss, significant loss of rods and cones, as you can see. Sister, again with a similar vision, and look at again the retina. If this child went to another, for routine examination, the child would be told that fundus is normal. So similarly, very, very well retained outer retinas, significant loss of rods and cones. And both these children carry 2 copies of mutation in the RP65 gene. So as gene therapy has become available, unfortunately for us, Luxturna is not going to be introduced to India. There was a time, I think the last 1 year, that a few of us worked towards its being launched in India, but it does seem like it's not going to be launched in India as of now. So this is one of the last cases. So we spoke about why therapy and then diagnosis and then therapy. This is for prenatal diagnosis. So this is a family of multiple members who are losing vision once they reach middle age. So you can see it's an autosomal dominant. So this is the gentleman who came to me. His father is about 75, 73 years old. That's his fundus with a significant vision loss in both eyes. And this is a condition called late onset retinal degeneration, and we identified that he carries a single copy. That's an autosomal dominant disease, and this is a son. The son was quite hopeful he would be okay, but when you look at these changes, you know that he's going to be a carrier of the same mutation. So unfortunately, he carried the same mutation too. Now, he was about 37, 38. He wanted to have a child. So how do we ensure that someone with an autosomal dominant disease has a child who's unaffected? So if the normal pregnancy, there's a 1 in 2 chance, whereas today you can do an IVF, and then, so there is something called pre-implantation genetic diagnosis that can be done. So what is done is, an IVF is done and a biopsy is taken from the embryo at the 8-cell stage. And then they are subjected to something called PGTM and PGTA. This was one of the first cycles that they did where every single one showed that there was an aneuploidy. That means if they had an IVF or normal pregnancy, I think a very high chance that they would have had another child with a similar problem. Thankfully, they actually got an IVF second time, and they found 3 embryos that were not affected, and they eventually went on to have a normal child. So I'm going to skip some of this. Maybe we'll discuss this in the therapy part of it. A lot of us have touched. We'll discuss this in the discussion bit. Thank you so much.
Thank you, Dr. Rajani, for that very interesting and interesting cases and how you came to the diagnosis. I think it's an eye opener for all of us. Slowly, we are warming up to the idea of doing genetic tests for our patients. And I think before we classify any patients as amblyopia or idiopathic, it's very important that we complete our armamentarium of tests, including genetic tests and electrophysiology, because patients are actually happy. All those patients were running from pillar to post with no diagnosis, and when you finally tell them, even if there is no treatment right now, that we have found what your disease is, they are hopeful that in the near future something will come up. So with that, if
I
you
just want to say a couple of things about the actual treatment that's on the anvil. While, like I said, it's not a great news that Luxturna is not going to be available in India. There are a couple of therapies, cell therapy, that are going through phase 1 and 2 trial. There is a company called JSide that is doing intravitreal cell therapy, retinal progenitors, and they've shown really good results at the end of 2 years. There is another company called Blue Rock Therapeutics that is doing photoreceptors for retinitis pigmentosa. So these are two cell therapy companies, and I don't know if any of you have had a chance to read. There's a subretinal, implant that is now coming up. So I do think the possibility for treatment for IRDs is quite wide now. In the next 5 to 8 years, a lot of these are going to be treatable. Thank you.
Thank you, Rajni. I thank all those who came to attend for this IC, and I thank my co-speakers also.